Hello and welcome to the Alabama Public Health Training Network. We're glad you could join us today for this program, Population Level Approaches to Child Physical Abuse Prevention. Our objectives today are to illustrate child physical abuse and violence in general as a public health problem, describe elements of a population-level approach to child physical abuse prevention, and to provide examples of population-level approaches to child physical abuse prevention. Before we get into things, as usual, we do have a couple of reminders for you. First, our phone number and email address are there on the screen. Make sure to write them down and use them at the end of the live portion of this program if you have questions for our faculty presenters today. Also, the handouts for this program are available online. You will need to register for this program in order to access those materials. This program is produced in partnership with Tulane University Maternal and Child Health Leadership Training Program. You can find more information on that program listed at the website on your screen if you are interested. All that being said, let's go ahead and meet today's presenter. Here in studio with me, we have Kathy Taylor. She's an associate professor at the Tulane University School of Public Health and Tropical Medicine. And a little bit later on, we will be joined by Dr. Seth Scholler. He's an associate professor of pediatrics at Vanderbilt University, and he will join our discussion by phone. We're thrilled to have both of you participate in this program. And Kathy, welcome.
Thank you, Christy. Welcome. Thank you so much for welcoming me, and thanks for having me today. Really happy to be here and able to talk about this very important problem. As Christy mentioned, I'm going to focus on why and how we should think about child physical abuse as a public health problem. And then I'm going to move into the second part of the talk and discuss the special ways in which I think public health can really make a contribution to the issue of child physical abuse, really thinking about the issue of prevention, as well as addressing the problem from a population level approach. And last, in the third part of the talk, I'm going to move into some very specific examples, some which might surprise you, and where I'm going to talk about what may be one of the most prevalent risk factors for child physical abuse and how we can address that from a population level. So, just to begin with, of course, the field of public health has been around for quite a while. But addressing the issue of violence as a public health problem is relatively new. It's really only been in the last few decades that, and especially in the last couple of decades, that we've really started to look at how public health can make a contribution to violence prevention in general. So I just want to start by giving an overview about how and why we can think about violence as a public health problem. So of course it has a very substantial impact on the population. We know that if we look at statistics from the Centers for Disease Control, if you focus on the red and green boxes, you can see the red represents homicides, the green suicides, and for a very large portion of the population, homicide or suicide is one of the 5 leading causes of death. So, of course, it's a problem of great concern in terms of mortality. In addition to that, of course, we're worried about quality of life and morbidity. So we all know that violence can lead to physical injuries and disability, and that's a big problem. Psychological harm is an incredible risk with being a victim of violence. We know it leads to post-traumatic stress disorder, depression, anxiety, and we also know that it can have a tremendous impact on social and behavioral health. So it actually can increase one's risk for becoming a future victim of violence, experiencing more violence, as well as being aggressive and potentially a perpetrator themselves. Not to mention just general addition of interpersonal challenges in one's life. But even beyond these risks that I think are more obvious, in public health we need to be concerned about some of the broader implications of violence and child abuse, which I'll get into in a bit. And that is that we know that experienced violence increases fear, it increases stress, it impacts lack of perceived safety, and this can impact a number of other health-related factors. So of course, if we're fearful or concerned about violence, this can make us less likely to go out in our community or engage in physical activity. It can also increase our risk for all kinds of health behavior problems such as smoking, substance abuse, and of course all of these can lead to greater risk for chronic disease. Of course, beyond the human toll, we have to worry about the economic toll. And this is really important, I think, for policymakers to be aware of, that this isn't just an issue of the human costs, which are huge, it's an economic toll. So upwards of $60 billion annually, just due to violent deaths alone. So it's a big problem. I'm going to move in now to talking a little bit more specifically about child abuse. A lot of the same kinds of risks and concerns apply, but there are some that are a little bit more specialized and important that I want to focus on. So again, I'm going to run through the impact on the population health first. So roughly about 1,500 children are actually killed from child abuse every year in the United States. We know that about half a million cases are substantiated every year, and around 3 million allegations, 6 million children investigated or involved in allegations each year. But for this talk, I'd really like the audience to think about those unreported cases, or the bottom of the pyramid. Mm-hmm. So we know these are the official numbers we have. These are the kids that actually come to the attention of CPS. But meanwhile, because of the nature of child abuse, often being in the home, often being a private issue, something that happens often out of the eyes of the public, many cases go unreported. And so I'm also interested in getting us to think about, how do we take care of those children? What can we do to prevent them from being abused, even when they may never come to the attention of authorities? In terms of morbidity, many of the same issues are relevant, as I already discussed, about violence, everything from physical injury, mental health issues, later chronic disease issues. And I'm going to talk more about some of the specifics of those as I go on. There's some work that I strongly recommend that folks look at if you haven't already heard of it. I'm sure many of you have read it, by Jack Shonkoff and his colleagues. But it's the concept of early toxic stress. And this is terribly important for this issue, and I think for people in public health and professionals who care about public health and child abuse to really get this concept in this framework, because what it does is it brings the issue of child maltreatment beyond just the very important issue of how children are impacted, but it also gets us thinking about how that impact on children can affect adults, or can carry on into adulthood and into physical health and disease risk. And there are two main ways that we understand that early toxic stress, childhood adversity, can impact later health. That's through, first of all, just the cumulative impact of trauma. So in other words, the more child abuse, the more adversity that a child experiences over time, the greater their risk for actually developing later disease. In addition to that, just by the very nature of the fact that infants and children's brains are developing rapidly when they're very young, it's a sensitive period to be exposed to any kind of adversity. And adversity and things like child abuse, the impact of that can actually be biologically embedded and can then have an impact on later health and disease risk. This is just to show you that given that issue of the sensitive period and especially the rapidly developing brain when a child's very young, keep in mind that unfortunately the victimization rate, child maltreatment victimization rates, are actually highest for the youngest children, or those children that are the most vulnerable. So we really want to think about how can we prevent abuse from even happening to those young kids. In terms of types of evidence that we can look at, there's all kinds of evidence that is cited. And first of all, there's epidemiological studies, so observational studies in the population that have looked at, again, the accumulation of adverse childhood experiences and how they add up to later chronic disease risk and health problems. We also have brain imaging studies, and these suggest that there's actually a direct correlation between child abuse and having an impact on neuronal networks that are related to behavior and affect in children. So this is an important finding. In addition, there are new studies that have been coming out in the last decade that are really important and fascinating for us to all know about. They're in the realm of epigenetics. And essentially what they say is that stress, such as child maltreatment, such as multiple kinds of childhood adversity, actually impacts the DNA. Mm-hmm. So this is part of the biological embedding we were talking about. We know that telomeres, or ends of DNA, are actually biomarkers for stress, for rapid aging, and for later chronic disease. And so it actually affects the DNA. And once again, in addition to the obvious human toll and a lot of the things I've already talked about, again, from a policy standpoint and thinking about resources and the economics, just the economic costs of child maltreatment are absolutely staggering. So total lifetime cost of new cases in the U.S., most recently estimated, this is a brand new study from 2012, estimates it at about $124 billion in a year. So I'm going to move on to what I hope was a little bit more of the hopeful portion of the talk, and that is to say why we can think about child maltreatment as a public health problem, not only for everything I just talked about in terms of the substantial impact on population health, but also because we can take a public health approach and apply it to this issue and hopefully contribute to prevention. So I'm going to move into talking specifically about that very piece, exactly what I think public health can contribute. I'll just mention that I think public health really, remind you that again, I think public health contributes by thinking about prevention and by thinking about how we can reduce risk on a population level. So just to go over elements of a public health approach, for those of you in the field, I apologize, this will be stuff you already know, but I want to just make sure we're all on the same page. Not everyone in the audience may have a public health background. So in public health, there's 4 major stages that we tend to go through when we're worrying about a public health problem. We first want to define the problem, and that involves surveillance and finding out how many people in the population have it, who has it. The next step, once we decide there is that problem, is we want to actually look at the causes, try to understand the causes and identify risk and protective factors of the problem. So that's the identifying the etiology. The third phase, once we actually know about these causes and risks, is prevention science. And that's where we want to, this is to me one of the more hopeful pieces. This is where we want to start taking all that information and developing, testing, and implementing programs that could actually prevent the problem. And finally, after we've gone through that third stage and we start to find programs that look promising and that are looking efficacious, then we can start thinking about disseminating, doing longer impact evaluation studies, and thinking about policy change, which is really exciting. I'm going to very briefly talk about where we are in the first 2 categories on this issue and then move into focusing the rest of the talk really on this idea of prevention science. So in terms of defining the problem, I've already given you some statistics, but thanks to the Child Abuse Prevention and Treatment Act, we have at least a couple of national surveillance studies to keep track of the number of cases. We have the National Incidence Study, which started in 1980. It's conducted about once every 10 years. And we have the NCANS surveillance, which is conducted annually. That's actually data that everyone can get for free in a report annually on the web in a document called Child Maltreatment and then whatever the year is. So the data that I've already presented to you in this pyramid, this comes from that data, from the surveillance data. I do want to take a moment here, though, to point out that remember that that surveillance data, of course, doesn't capture the bottom of the pyramid. It doesn't capture those children that never came to the attention of authorities or other community professionals. We want to keep those kids in mind. We've also done a lot in this field to identify the etiology of the problem, to really try to understand risk and protective factors. And for this, I'm not going to provide an exhaustive review. That could be a whole other talk, but I just want to give you a little bit of a sense of some of the things that we do know about the causes of child maltreatment. And in public health, we often use the social ecological model as a framework for prevention. I'm sure all of you have heard of this or seen it. And the concept is relatively simple, but it's important. It's the idea that risk and protection and causes are not limited to just the individual, but they're also, they extend to spheres of influence outside of the individual. So relationships in that person's life, the broader community, and even the broader society and culture at large. So what I'm going to do is go through each of those levels from individual to societal and just, again, give a few examples. And then I'm really going to be focusing the third part of the talk on this societal level. So at the individual level, we know a number of things. So for example, we know that if a parent witnessed violence as a child, if they were exposed to violence or a victim of violence even in adulthood, or if they have attitudes that are supportive of violence, which may be linked to their own experience, that increases their risk for perpetrating child abuse. We also know that parents that are lower in knowledge have less of an understanding about parenting skills, about child development and what are appropriate expectations for children at certain ages. This is very much linked to child physical abuse, and one of the issues that can come up is parents can develop negative attributions for kids. So let's say that a kid is acting out, they're throwing a temper tantrum, maybe they're pulling a parent's hair because they're frustrated, they're screaming, they're crying. A lot of these things are, of course, quite normal. Every parent knows this, but sometimes parents can take that personally or take it as something that the child is actually doing to be harmful to the parent. And when those things happen, and that can, again, be very much linked with knowledge of expectations at different developmental stages, that can put the parent at risk for abusing the child. Of course, we also are aware of things like drug abuse, substance abuse, and emotional reactivity or impulsivity that can put a parent at risk. So moving on to that next level in the model, the relationship level, a few things that I want to draw your attention to here. First of all, we know that raising kids is an incredibly difficult job and very stressful, even with a lot of support. So we certainly have lots of evidence that parents that are socially isolated, that have low social support, those parents are at tremendous risk for abusing their kids, especially when you add on these other risk factors I've talked about. Another important interpersonal level, relationship level factor is the presence of relationships, but what I would say more harmful or risky relationships, in that they have demonstrated to the parent that using violence to solve conflict, to solve problems, is okay, is acceptable. So where violence has essentially been modeled. So whether that's in the family of origin, whether the parent maybe witnessed that between his or her parents, or experienced it as a child, maybe it was in their peer group growing up that they saw a lot of violence going on, or in their intimate relationship or marriage. And of course, this operates through a process most of us are familiar with, social learning, which we know, of course, children learn how to parent from others. So if they see violence, they witness it, they've experienced it, this becomes embedded and understood as something that's acceptable and that they maybe can or ought to do. Moving up to the community level, there are a number of things to think about. Again, keep in mind, not an exhaustive list, but just to give some examples. We know that high population density, overcrowding, think of that as being linked with stress, can be a problem. We know that communities that have lower access to child care for parents, to provide parents with additional support or other services, can raise risk. And we also know that communities that have a low collective efficacy, now what is that? It's kind of a fancy term, but really it basically means that communities in which parents feel that maybe others don't have their back, people aren't really looking out for each other, there's not a strong sense of civic duty or a sense of belonging. So communities in which that is prevalent can raise risk for child abuse. I'm going to move on to the last level, and I'm just going to give one example here. There are certainly others, but one that I want to focus on are norms that hitting children for the purposes of discipline are acceptable. And I should have added that to this slide, but I've implied it below, because hitting, usually we don't say we're going to hit kids for physical discipline, but we say things like we're going to use corporal punishment or physical discipline. In schools, the term paddling is often used, spanking. All of these things, however, boil down to hitting children for purposes of discipline. And so that norm, that's acceptable and that it's very common, I'm going to argue is one of the societal level risk factors that we need to think about more in terms of primary prevention of child physical abuse. So now, as promised, I'm moving into what I consider some of the more hopeful things, and that is where we are in prevention science. And it's always important when you're about to embark on thinking about designing and developing interventions to be really clear on what your target groups are for intervention and also what kind of timing you're interested in regarding prevention. So let me say a little bit more about what I mean by that. So starting with the blue circle, or the smallest group, we can think about targets for intervention in terms of different levels of risk, let's say, for the outcome of interest, in this case, child maltreatment. So we could focus our interventions on the smallest group here, those parents that have already perpetrated child abuse, the indicated level. We could also focus our interventions on, say, those parents that haven't abused, but we know are at risk, where we've looked at a number of the risk factors and we can say safely they're at high risk, let's focus our interventions on them. Or we could take a more universal approach where we say, you know what, this is a population level problem, let's look at the whole population and target that whole group, or target all parents or most parents and not be overly selective. And frankly, that is essentially synonymous with what I'm calling a population level approach, is taking this more universal level as a target. In terms of timing of prevention, we can think about primary, secondary, and tertiary prevention. So primary prevention being focusing on preventing the abuse before it actually occurs. CPA here stands for child physical abuse. Secondary prevention is really focused on addressing child physical abuse right after it occurs, so dealing with acute care for the victims. This is really where our child protective services in this country is really focused primarily, is on, a case is identified, and then what do we do to try to make sure it doesn't happen again. So we do have a lot of resources, or we have a decent amount of resources dedicated to secondary prevention. Tertiary prevention, also very important, is focused on the longer term care issues. So I've mentioned all of the morbidity and quality of life issues that can occur after a child's been abused: mental health, behavioral health, social health, later chronic disease. So tertiary prevention refers to dealing with a lot of those issues in terms of caring for the child, but as well as working with the parents to try to, again, make sure that the abuse doesn't occur again. I'm going to focus for the rest of the talk on primary prevention. So I'm really interested in talking about what we can do better as a society in terms of preventing child physical abuse before it begins. Remember, I'm thinking about all those kids out there that never even come to the attention of the authorities, and that frankly we don't want to ever have exposed to child physical abuse if we can do something about that. So I'd like us all to really think about that, how we can do something about it if we can, and I'm going to propose some ways that we can all potentially do that. So let me first argue more specifically about why I think we should take this population level approach and what exactly that means, and how does it compare and contrast with approaches that are already very much in use. So first of all, most prevention programs that are currently ongoing in the United States focused on child abuse prevention are geared towards high-risk individuals. So if you think back to those circles I put up there, they're really focused on the smaller circles. So either those parents that are already known to be at risk for abusing their children, or that have abused their children. And these programs, very important, and they're focused on trying to decrease the risk of those individuals to that of average individuals, or even lower. So trying to lower their risk. This is very important, and it's an important strategy. And just to give you kind of a visual of this, let's say this curve represents the population, with most people, of course, falling into average risk for abusing kids, but then we have low and high risk. Sometimes this is called a curve chopping approach. So again, we're trying to focus on that high risk end of the curve and move them down to average risk. So just some examples to make this a little bit more concrete. Sometimes it's hard to wrap your brain around what this stuff means. So we've all probably had the experience of being screened for high blood pressure, right? Every time we go into the doctor's office, and often for high cholesterol. And so we're being screened to see if we are at high risk for the diseases that are linked with these markers. And so this is a high-risk approach. We're trying to then identify these and then treat these high-risk markers if they're present. In the issue of child maltreatment, we have a number of wonderful programs that fit into this high-risk approach. Nurse home visitation to families. I'm sure everyone, or most folks listening, if not everyone, has heard of the nurse-family partnership. There's incredible amounts of evidence that this program, which is so important, has been shown to reduce risk of child maltreatment and even improve maternal outcomes, so both maternal and child outcomes. Really important program, but it's also a very intensive program, right? It involves bringing a nurse into the home. So we don't have that. We don't have the resources, at least for now. Who knows if it'll happen someday, but as of now, we're focusing our resources, understandably, on those families that are at highest risk with that program. So with that in mind, I now want to get you to think a little bit differently for those of you that haven't heard of this concept. I'm sure many of you have, but some of you haven't. And it's called the prevention paradox. And this is the idea that just making small decreases in risk that occur in the entire population can actually have a greater benefit on population health than large decreases in that high-risk subgroup. So that's kind of a mouthful. So I'm going to try to break it down and again use some visuals to give you some examples of what I mean by that. So using the same curve idea, rather than taking a curve chopping approach, this is actually another way to think of it as a curve shifting approach. So we're interested in that whole population of folks out there and actually just trying to lower everyone's risk. Now, there are a number of benefits to this, and there are some good reasons for doing this. One might be clear. It's just that we're impacting the entire population, and this is a population level problem. I want to emphasize that I'm not saying that one is better than the other. I think we need both. So child maltreatment is a very big problem, and I think we need both the curve chopping and curve shifting approaches. But let me just focus for a minute on what I think, not just me, what I know has been said and written about some of the benefits of taking this curve shifting approach and some things we can get from it that we might be missing in some of the other approaches. One of the benefits is that the curve shifting approach actually usually aims to address root causes of a problem in a population. So let's take the cholesterol example again, because that's something that most of us are familiar with. The high-risk approach, again, is looking for those high-risk individuals who's got high cholesterol, and then let's treat them. So people already have the problem. They already have the condition. Population-level approach says, you know what, let's identify some of the factors in our population that are putting everyone at risk. And let's lower those factors, especially if they're factors that aren't doing anybody any good. And a great example of that is trying to reduce population level of exposure of trans fats or partially hydrogenated fats. Those are those fats that there's apparently no evidence that they do anyone any good at all. And it would be great if we could get rid of them. And so there actually have been efforts to, I'm sure many of you have noted that now when you look on your food containers, you can often see very clearly how many trans fats there are. So you can look for food that has none. Lots of food advertise 0 trans fats. And then we also have some places that have actually banned trans fats, such that restaurants just can't use them, for example. So that's, again, we're trying to lower everyone's risk. If fewer people are eating trans fats, then all the negative things that come from that, we don't even have to worry about treating everyone with high cholesterol, right? We can just hopefully lower the risk for everyone. That's one benefit. Another benefit is this idea that the larger population influences the tail, or another way to think about it is that behavior is contagious. And one way I like to think about this is just imagine that you're trying to get motivated to run. I don't know about you, but this is a daily struggle for me. It's like, make sure I get my exercise in. And I know that I'm more motivated to do it if I have friends calling me up saying, hey, we're going for a run. If I'm looking outside and I see people exercising, the guilt kind of starts to set in and I start thinking, maybe I should exercise. So it's easier to move towards good or healthy behavior when we see examples of it in the larger population. And so basically we're going to spend less time trying to convince people in the high-risk group that they ought to move this way. If everyone's moving this way, it'll be a more natural shift. So that's another benefit to consider. And finally, An important point is that this kind of approach actually has strong potential for affecting population attributable risk. So that's another fancy word. But essentially, it's a really important measure that we can think about and that public health professionals often use when they're trying to judge priorities for public health interventions, right? We know of all these risk factors, we have all of these major public health problems, and we have limited resources. So we have to, of course, we policymakers, leaders in the field have to ask themselves, where do we want to put our resources? And so population attributable risk is one of those things that helps us to figure out where to put resources and where we can hopefully get the most bang for the buck. So what is population attributable risk dependent on? Well, it's dependent on two key factors. It's dependent on the magnitude of the association between the risk in question and the outcome of interest. And it's also dependent on, and actually very much dependent on, prevalence of whatever that exposure is in the population. So if the exposure is highly prevalent in the population, and it's even somewhat moderately associated with risk of the outcome that we're interested in, then population attributable risk is going to be high, and we want to try to focus on that. So that brings us to part 3, where I'm actually going to move into some specific examples, and I'm really going to focus on one social level factor in particular that I'm going to argue I don't think we've spent enough time on in this country in particular, and I think we could do more on, and that children could really benefit from it. And that is the idea of focusing more efforts on shifting social norms regarding corporal punishment. So I'm going to make the case for why I think this is important, and of course I'm looking forward to your questions about it. I'm sure you'll have some. So first of all, why focus on corporal punishments? Well, we know that, as I've already stated, that if we focus on factors in a population that are highly prevalent, we can generate greater impact on the problem than if we target those factors that are less prevalent, even if they may be more strongly associated with the outcome of interest. So again, prevalence of a risk factor is very important when we're thinking about what to focus on. So that's one point. I want to take a minute to just define corporal punishment, or give a definition of corporal punishment that I refer to often, just so we're all on the same page. What am I talking about when I say this? So the definition I'm working from is corporal punishment is the use of physical force with the intention of causing a child to experience pain but not injury for the purposes of correction or control of the child's behavior. That's the definition I'm working from. And actually, I'll come back to some more of that in a minute. So why focus on corporal punishment? So social norms regarding physical discipline or corporal punishment may be the most prevalent risk factor for child abuse in the United States. And that's a really important factor to consider, is that if it's one of the most prevalent risk factors, why aren't we taking it more seriously? I think there's an important point to mention here, and that is that I know that a lot of times when people hear this, one of the first things they start thinking is, well, I was spanked when I was a kid. I experienced corporal punishment. I'm absolutely fine, and I'm not quite sure that I understand how social norms are such a risk factor for child abuse. I'm going to get into some of the evidence on that in a minute. But I guess I want to just remind people to think about other public health examples where, even though maybe as children, I can think, for example, that I know when I was growing up, I don't think I sat in a car seat. I don't think we had car seats when I was growing up. And I was certainly exposed to all kinds of secondhand smoke, and other things like that where, I know a long time ago folks thought that drinking during pregnancy was okay, or excessive drinking, smoking. These are all things that, although they were done in the past, we have evidence now that they're harmful, or they raise children's risk for harm. And so from a public health perspective, if we uncover something that we realize is harmful to children, that has no particular benefit, and that's unnecessary, let's think about ways that we can change it for children's health. So that's the perspective that this is coming from, and I'll, again, provide some more evidence on this. So in terms of the prevalence issue, I've stated a number of times it may be the most prevalent risk factor. So number of studies that have looked at this. The first piece of data there, the first bullet, refers to some data that's fairly old now. It's about a couple decades old from Murray Strauss and colleagues. And it showed that, this was back in the 90s, that about 85 to 94% of U.S. parents use corporal punishment for their 3 to 5-year-old children. So again, the point being extremely common. Most people do it. Most people have experienced it. So it's something we kind of take for granted. It's just part of our culture. In a more recent study that I did with some of my colleagues, we found that about 2/3 of 3-year-olds had been spanked by one or both parents. So point there being that we're still talking about a majority of children who are corporally punished for discipline. This is a chart from Child Trends Data Bank. I borrowed this straight from their website because I think it's such a great visual. And it shows that they've been tracking the question for over 25 years now, asking, do you agree or strongly agree that it's sometimes necessary to discipline a child with a good hard spanking? I think one of the key words here is necessary. And back in the middle 80s, we saw that about 80%, more than 80% of both men and women believe that it's necessary to discipline a child with a good hard spanking. The attitudes and approval ratings have gone down in the U.S., but as you can see, they haven't gone down all that much. We still certainly have a majority of folks out there, more men than women, believing that it's necessary to use corporal punishment in order to discipline children. So the other factor that I want to move into is, so we've established that it's prevalent, and you probably didn't even need the data to see that. You know from, again, your own experience, it's highly prevalent in terms of it happening and in terms of positive attitudes towards it. But the other really important factor to know is that it is strongly associated with risk for later child physical abuse victimization. This particular study I'm citing was a meta-analysis done by Liz Gershoff, showing a medium to large effect size linking corporal punishment and child physical abuse. So once again, many of you may be thinking, well, I'm surprised it's such a high risk. I experienced it, my kids experienced it, I'm fine, they're fine. Again, I ask you to think about other examples in public health. So let's even take smoking, something that at this stage, I think you'd be very hard-pressed to find anyone who thinks smoking's good for you or necessary. But we know that certainly there are people that smoke who don't develop disease or do fine or live into their 90s or beyond. So being a risk factor doesn't mean there's an exact one-to-one correlation between the risk and the outcome. It means that people exposed to that risk factor are at increased risk for whatever the outcome is. And there's really no debate, if you look at the data, that corporal punishment is a risk factor for child physical abuse. Other thing I want to point out, since I'm focused on this topic and it's going to be relevant very shortly, is that there are individuals in countries around the world that are concerned about this issue, not even because it's a risk factor for child physical abuse, but just because they're looking at it as a children's rights issue. Now today, I'm not talking about it from that perspective. I'm not addressing it from a pure children's rights perspective, but I want you to be aware that that perspective exists because it's very prominent. It's really based out of the UN Convention on the Rights of the Child, so you can learn more about that if you're interested. But there are a number of countries that have adopted the stance that simply by virtue of the fact that children have a right not to be hit, not to be assaulted, as we take for granted as adults, that also applies to children. So I just want you to be aware that that's one way of addressing the issue. What I'm asking you to think about today is, even putting that aside, we know from the data that corporal punishment is a very strong risk factor for what I think we can all agree is abuse. In other words, abuse that leads, physical abuse that can lead to injury and damage to a child. So here's some other data on that point. Adam Zolator did a nice study looking at how the odds of child physical abuse increase if spanking is present. So we know that when spanking is present, they go up by about 3 times. When spanking with an object is present, they go up by about 9 times. Makes sense, I assume, right? Because even though, as I said, corporal punishment is meant to inflict pain but not injury, intention doesn't necessarily mean injury won't happen. That's another thing to keep in mind. So in addition to the fact that we are concerned about it just as a corporal punishment, as a risk factor for child physical abuse, it also is linked with other poor outcomes that we're not looking for in our children, right? We don't want our children to be at higher risk for poor mental health, for aggression, for delinquent or antisocial behavior, but there's lots of research, especially on the aggression point, showing that children that are experience corporal punishment are at increased risk for being more aggressive. Yes, we know that children that are acting out more are at higher risk for being corporally punished or physically punished, but we also know that even controlling for that, even controlling for the child's behavior, that they're still at increased risk for being even more aggressive. In other words, corporal punishment in the long run, it may feel like it's working initially, it may be that quick fix that feels like it's working initially. In the long run, the evidence, again, suggests predominantly risk for children. So, just as a quick summary, we're focusing on corporal punishment both because it's a strong risk factor and because of its high prevalence in our society. So now, the bigger and the tougher question, frankly, is how can we actually make a difference about this? How can we shift these norms around corporal punishment? So, first of all, from that population level and perspective and focusing on primary prevention, there's a couple of broad strategies that we can use. We can think about legal or policy interventions that are enacted at an entire community or even national level at times. Or we can also think about broad educational interventions like media campaigns. So I'm going to go through some examples of each of these just so you have some idea of what I'm thinking about. I'm going to start with corporal punishment bans. So I'm not sure how many of you are aware, I'm sure many of you are, that universal corporal punishment bans even exist in the world. So what is a universal ban on corporal punishment? It means that in some countries they've determined that they want to ban corporal punishment altogether, meaning, again, many of these coming from a children's rights perspective, but also now building from the evidence we have about all the harm linked with corporal punishment. Some countries have decided to enact bans at a national level saying it's not okay to use corporal punishment even in the home. And this graph shows you the way that trend has gone. So we now have 33 countries that have used universal bans on corporal punishment. These were started in 1979. Sweden was the first country to adopt such a ban. And as you can see, in the past decade, the growth of countries that have been adopting such bans has really grown exponentially. I'm just going to quickly flip through a list of slides that give you in chronological order the countries that have passed such bans, just so you can see for yourself. And of course, I've provided a site there, so if you want to look up more information on this, you're of course welcome to. So again, Sweden was the first country. These are mostly European countries that were initially doing this, and then we moved on to some other countries, including New Zealand, Republic of Moldova, Kenya. So we have quite a variety in there up to the present day. So what are some of the objectives of bans? And I want to again use Sweden as an example just because we have the longest history with the Swedish ban. And one of the big objectives was to establish a clear boundary that just gave the message that there is no level of hitting of a child that's acceptable or that's going to benefit a child. And we don't need to wait for there to be visible harm. That's what we currently do. That's, again, what we consider child physical abuse is there usually needs to be some evidence of harm, of physical harm, of visible harm. And the bans are saying we don't want to wait to that level because we know that any level of this early toxic stress and adversity in children can do some harm even if it's not visible. So we want to get out in front of this, again, a primary prevention perspective, and try to provide parenting support to parents that need it, that aren't really sure what their options are besides physical discipline. Some parents just don't know. That's what they grew up with, and so that's what they use. And so those parents that don't have other tools just need some support to be shown what are some of those other options that are as effective and not harmful. And of course, one of the other key objectives is just to keep altering attitudes. So of course, in order for a ban like this to go into effect, usually the attitudes have to be coming down anyway. There has to be a decrease in approval, but with a ban in effect, the attitudes are going to shift even more. In the United States, of course, everyone knows we don't have a universal ban, but we do have bans on corporal punishment in schools. So there's certainly a recognition that corporal punishment is not necessary to discipline children. And this map shows you that we have 31 states in the United States that have banned corporal punishment in schools. We do have 19 states where, in red, where corporal punishment is still legal, although of course on a city or county or specific school level they may have enacted their own decisions to ban corporal punishment. Just to show you, this has been in the news, it's been discussed and debated not that long ago. It was in the New York Times, a story talking about these corporal punishment bans in schools. At the time, there was a proposal in New Mexico that was passed. As you can see, New Mexico is now one of the states that has a ban. And there actually has been some effort on a national level by Representative Carolyn McCarthy, who's introduced the Ending Corporal Punishment in Schools Act, where she hopes to, at some point, this is not passed, but to see if there's a way to end corporal punishment in publicly funded schools and actually take money and give some money to schools to fund positive behavior support approaches. So we know there's lots of ways to discipline children, to provide consequences, and to promote positive behavior, which is ultimately what we want, right? We want to raise good citizens and have kids be healthy and behave positively. So this would help to fund schools to promote that as well. So do bans work? So this is a tough question, right? But we have some evidence and some thoughts about this that I want to just get you thinking about. So again, first of all, let's take Sweden. That's the longest running example we have. I think it's important to keep in mind that in Sweden, this ban was enacted within a context in which there was very broad support for children's rights. So that's one thing. Again, I talked about this whole piece that just focuses on the rights of children, just not to be hit for any reason. So that context was strong in Sweden. And I think it's probably strong in a lot of countries where there's a country level ban, or it needs to be fairly strong. In addition, there's a policy framework in Sweden that really was focused on prevention. And as I've been saying today, I think one of the strengths of the public health approach is to get us thinking about what are some of the things we can do to prevent child physical abuse from happening in the first place. And that prevention framework was very strongly in effect there. So the attitudes were already coming down in Sweden. I think you might say there's a little bit of a chicken and the egg. Well, did the ban make the attitudes come down, or did, or was it the other way around, that just the attitudes changing made the ban happen? So it's always very difficult to answer these broad policy questions, right? We know this in the election right now, people claiming a policy worked or it didn't work. But I guess what I, again, would draw your attention to is just a common public health example that we all are super familiar with, and that's smoking. And smoking bans in specific places. And so I would just ask you, those of you that are old enough, like me, to think about, back when, let's say you were going into a restaurant and smoking was allowed, and what the attitudes were about that. And maybe you didn't like it, but you certainly put up with it because that was just the norm. Back in the 50s, when they were doing a lot of reviews of the epidemiological studies about smoking, doctors were smoking, lots of folks were smoking. Just that knowledge that it was really harmful just wasn't out there yet. And once that knowledge started to get out there and bans started to be enacted, I think there is this synergistic effect of shifting attitudes and shifting behaviors. So I think bans can help in that synergistic way once the information gets out there. Now, speaking of getting the information out there, I want to talk about the educational approach, because really I think we need to do a much better job right here in the United States about just getting the word out there about this issue, and about helping parents to come up with alternatives to corporal punishment, given that it's not effective, it's potentially harmful, and it's not necessary, and it's a risk for child physical abuse. So what are some ways we can do that? I'm just going to briefly, from the mass media perspective, talk about just some examples that, again, I've provided the references and you're welcome to look them up and learn more about them, but some examples of promising campaigns that have been done using PSAs, using other kinds of mass media, and that have shown some promise in these evaluation studies in reducing some of the factors I've talked about linked with child physical abuse. So Florida Winds of Change campaign, the Campaign for Action on Family Violence are a couple of examples. And one big example that involves this approach, probably most of you, if not many of you, have heard of, is Triple P. And Triple P is fantastic. It's got some of the, probably the best evidence that we have right now of a population level of approach being somewhat effective, being effective in reducing child abuse risk. The one thing I'll point out, however, about Triple P is it's really just that level 1. These are different levels of the intervention, but that level 1 is really the only purely universal approach. That media campaign, which is designed to really lower, my understanding is designed to lower stigma about parents seeking help. So a really important component, but this also combines these other more targeted levels. So there are some very intensive parts of the intervention as well, where, say at level 5, they're really trying to target those parents that are at high risk and provide more intensive services. So it's very comprehensive. It's going to involve more resources than some of the examples that I've given that are working purely on that universal level. And lastly, what I'd like to talk about is probably the area that I'm personally most interested in trying to do more work in. I don't think we've done enough in this area. I think we have a lot more that we can do in both of these educational interventions, and that's engaging community leaders. And so why should we engage community leaders on this issue? Well, one of the reasons is because parents' beliefs about what certain community leaders believe about the issue of corporal punishment are actually tightly linked with their own attitudes about corporal punishment. This is from some research that I did in New Orleans. And so in other words, if a parent believes, let's say their pediatrician is supportive of the use of corporal punishment or thinks that using corporal punishment is a good form of discipline, that's very much linked with the parent having very similar attitudes. Now, the other reason to care about community leaders is because there are some community professionals that parents listen to as much as their own family members when it comes to getting advice about child discipline. And again, from some work I've done that I've referenced, we know that pediatricians are among the top in that group, as are religious leaders, mental health professionals, and some other professionals. So we can actually go to people who see parents all the time, pediatricians, religious leaders, mental health professionals, and if we can work with them around what they think about this issue, around their knowledge of this issue and why it might be important to help parents find non-physical discipline alternatives, that can really, I think, has the potential to have a huge impact on child physical abuse at the population level. So thinking just more specifically and thinking about religious leaders, so one of the reasons religious leaders, especially Christian religious leaders in the U.S., happens to be an important focus. One reason is, of course, just Christianity being the majority religion here, but in addition to that, in a study that I have in press, those parents that were more likely to seek advice about child discipline from their religious leaders versus pediatricians actually were at higher risk for using corporal punishment. And of course, I'm not talking causality here. It's hard to say which direction that's going. Is it just that parents that are more at risk for using corporal punishment are tending to seek advice from their religious leader, or is it that some things that the religious leader is saying may be perceived as condoning corporal punishment. Who knows? But either way, it's important that I think we try to work with religious leaders around this issue and frame it in the very real way that we're interested in children's health and well-being, not just now but in the long run, and how can they work with us as professionals to improve that. So for that, I've just provided you with a couple of resources for anyone who's more interested in that and learning about some examples globally, so you can take a look at those if you're interested. And the other group that is incredibly important, and we're going to hear from, is the pediatricians. And they're incredibly important for a couple of reasons, for multiple reasons. But one of the reasons is that when I asked parents about who they were most likely to listen to for advice about child discipline, pediatricians ranked up there, right up there with family members. They were just as important as family members. And so that's one reason. The other reason is that pediatricians see most of the children in the United States, right? It's kind of the best we can get to in terms of personal universal access to kids in the United States because of wellness visits. So parents listen to pediatricians for advice about this, even though not all pediatricians may know that or be aware of it. And their advice is incredibly important, and their attitudes and what they tell parents really matters. So I think there's a real opening there to work with pediatricians. I know pediatricians are already, those in the audience may be sighing, they already have too much to do and they're overburdened with things that they have to communicate. But I think we can work with pediatricians to find ways, to find just even small ways to communicate, again, that there are options to corporal punishment. So a couple programs that I'll mention, this one by Howard Dubowitz, the Safe Environment for Every Kid program, or SEEK, trains pediatricians and other primary care docs to screen for psychosocial risk factors for child physical abuse, and has shown some efficacy and a lot of promise. So that's one you can look up if you're interested. And another one by Dr. Seth Scholar, and he's actually the one who's going to join us, which I'm so happy about. So he can give you a really concrete example about an intervention that he's been working on and developed as a video tutorial to help educate pediatricians and parents about alternatives to physical punishment and some child discipline and behavior management strategies. So that's coming up. So before I turn it over to Dr. Scholar, I just want to draw some conclusions and sum up some of the main points that I hope you'll take away from this talk today. So probably most people joining, even before they heard the first part of the talk, realized that child maltreatment is a very significant problem, and it's not just the economic costs, which of course are huge, but the human toll of child maltreatment. And it's not just what's happening to kids when they're kids, which in and of itself is a very large burden, but it's also the impact it's having on those children's futures in terms of their health and well-being. Child maltreatment is really setting up this trajectory, if you will, for poorer health and for poorer outcomes. And I think we have an obligation as public health professionals to find ways to prevent that before it happens, to get under it and get on top of it, so that we're not spending all kinds of resources focused on finding those kids, treating those kids for the trauma, and dealing with the aftermath down the line of paying for chronic heart disease and other major health risks that the kids have been set up for. So I think, again, that we need both high-risk and population-level approaches. We need to keep going with those programs that work with high-risk families, like the Nurse Family Partnership that David Old spearheaded, wonderful program. So we need to keep working on those programs, but we need population-level approaches too. And I think, given everything I've laid out here, that we need to keep in mind these approaches really have the potential to reduce child physical abuse incidents and lower costs. I think they can be potentially very cost effective. And so we need to do more to design and test them. And finally, I'll just say that, as I mentioned, those very broad strategies, the legal, policy interventions, as well as educational interventions, we have a number of fantastic examples in public health where these kinds of efforts, legal policy and widespread educational efforts have worked in tandem to improve public health. Think about things like drunk driving, think about tobacco use, think about seatbelt use. So we have used, and frankly, also in some efforts around obesity and diet. So we have examples where we have used this approach effectively and combined these approaches effectively. And I hope that some more folks listening today will consider how you can engage in this very important issue in combining these population-level approaches to improve children's health and to help prevent them from ever having to experience physical abuse. I just want to leave you before Dr. Scholar joins us with a couple of resources. There's, of course, many more than this. But whenever I give a talk like this, I always get a lot of questions about, well, where do I send parents, or what kind of advice can I give parents if this isn't your particular area that you're super familiar with. So here are a couple of resources that you can start with that talk about actual examples of implementing positive discipline strategies that don't involve corporal punishments. And I know they're going to have access to these slides. Is that right, Christy?
They do.
So I know you may not be able to read these references, but you'll be able to read them when you get a copy of the slides. So everything that I've presented here should be referenced, and of course you're welcome to look it up. And I think we're going to do questions later, right? But first we're going to go to Dr. Scholar.
Yeah, Dr. Scholar, are you on the line with us today?
Yes, Christy, I am.
Great. We're so glad to have you here, and you have some big shoes to follow here with a great presentation from Kathy, but I know you have some great information as well. So why don't you go ahead and kind of continue on with her discussion. I know you're focusing a lot on corporal punishment as well.
Well, thank you, Christy, and thank you, Kathy, and thank you to the Alabama Department of Public Health for sponsoring this live webcast, and I'm really excited to be a part of it and to pass on some of the information and data, some of the research that we've collected over the years related to early brain and child development and how a brief intervention might be able to affect attitudes toward physical punishment. I do want to disclose that the presentation will include a discussion of research on an educational program called Play Nicely, which is owned by Vanderbilt University and of which I am one of the authors. The program can be viewed at no cost at www.playnicely.org if you're interested. The goals of this presentation are to review toxic stress and health problems related to toxic stress, to review research findings of a brief intervention designed to mitigate toxic stress with a focus on discipline, teaching alternative discipline strategies and positive parenting, and we will focus on research that we've conducted over the years related to how we might be able to change parents' attitudes about physical punishment. I want to start this talk by just mentioning that much research and discussion has surrounded the issue of early brain and child development. We know now that there is a concept called epigenetics in which there are genes that are turned on and off depending upon a person's exposure, environmental exposure, and that we have learned over the years that chronic exposure to toxic stress in the early years can result in permanent changes in the brain architecture and how the brain functions, which can then lead to adverse health consequences. And that the toxic stress of some environmental exposures can affect early brain and child development that can have long-lasting effects. A few words about stress. Not all stress is toxic. There actually are what are considered positive stress responses, which are a normal and essential part of a healthy development. An example of this in pediatrics, for example, might be when a child comes in for their well-child visit and receives a vaccine in clinic. There are examples then of higher levels of stress, which are generally categorized as tolerable stress response. And in this situation, the stress will activate the body's alert systems to a greater degree, and may or may not result in long-standing or more difficulties. An example of that might be, for example, a loss of a loved one. Now, the feeling is that with the tolerable stress category, that protective adult relationships can help buffer the stress and help a child return to baseline. In contrast to the positive stress syndrome and tolerable stress responses, there is a category of stress referred to as toxic stress, and that occurs when a child experiences strong, frequent, and or prolonged adversity. And examples of that include physical or emotional abuse, chronic neglect, caregiver substance abuse or mental illness, or exposure to violence that might go on for months or years. And these toxic stressors can have adverse effects on a person's health. And some of these are referred to as adverse childhood experiences, which can result from exposure to toxic stress. And it's interesting that these adverse childhood experiences can result in multiple health problems. Over the years, researchers have found that exposure to toxic stress and adverse childhood experiences such as chronic harsh physical punishment or child abuse is linked to multiple problems, including alcoholism and drug abuse, smoking, ischemic heart disease, liver disease, intimate partner violence, depression, suicide attempts, and a decrease in health-related quality of life. Moving on, we know that toxic stress, child abuse, and physical punishment are linked in a certain way, and that is that one type of toxic stress, as discussed, is child abuse, and that physical punishment, although in many circumstances will not have any long-term effect, in some situations can lead to child abuse. And I really like Kathy Taylor's example of smoking. We know that some people can smoke for decade after decade after decade, and they will have no ill effects. They will have no lung cancer, no chronic pulmonary disease. On the other hand, we know that some people who smoke will go on to develop chronic lung disease, and they can develop lung cancer. And so similarly, physical punishment, although it can end up having no long-term effects for many children, in some situations can lead to adverse problems. There was a policy statement written by the American Academy of Pediatrics that phrased things in a way that I think can be understood at some level for those children who are at greatest risk, and that physical punishment can sometimes lead to child abuse. And as quoted from the AAP policy statement, quote, "The only way to maintain the initial effect of spanking is to systematically increase the intensity with which it is delivered, which can quickly escalate into child abuse." Kathy Taylor mentioned the meta-analysis that was conducted by Elizabeth Gershoff, and in her meta-analysis, she looked at physical punishment and some of the adverse health consequences that can be associated with physical punishment. And there have been multiple adverse consequences that have now been identified to be associated with physical punishment, and those include an increased childhood aggression and antisocial behavior, decreased quality of parent-child relationship, increased risk of being a victim of physical violence, increased adult antisocial behavior, decreased child and adult mental health, and an increased risk of abusing your own child or spouse as an older person. I am a general pediatrician, and my background is that I am really interested in trying to figure out ways how to improve our primary care offerings as we see children and their families for the multiple well visits for which we see them. And this slide demonstrates the well child care visit as outlined by the American Academy of Pediatrics. And one of the components of the well-child visit is anticipatory guidance. And as part of the well visit, the American Academy of Pediatrics recommends that we include anticipatory guidance related to violence prevention and child abuse prevention as part of the routine primary care offerings that we provide for families. And the American Academy of Pediatrics, as a quote from them, corporal punishment is of limited effectiveness and has potentially deleterious side effects. And the American Academy of Pediatrics recommends that parents be encouraged and assisted in the development of methods other than spanking for managing undesired behavior. And that's all very nice. We are learning more and more, as Kathy discussed, that we need to do more to try to teach parents about how to use alternative measures to discipline their children. But the big research question that's on the table right now is, can we really do anything within the context of the well-child visit, within the context of seeing a child and their families for sometimes only about 20 minutes? Can we develop a brief intervention that can teach parents about discipline and to not use physical punishment within the setting of the pediatric primary care visit? And another setting in which we've done some research is in the preschool setting. The intervention which we have been studying over the years is a multimedia program, and the meat of the program is a interactive portion in which parents are presented with multiple different options to respond to the hypothetical situation of one young child hitting another, and then parents can click on the different options and learn about why redirecting a preschooler or setting the rule or maybe doing some role play with a child is a lot better option than using physical punishment. The intervention is available in both English and Spanish. Before I speak about some of the studies, I want to mention that in our Vanderbilt Primary Care Clinic, the demographics of our parents are essentially the demographics of an underserved population. Approximately 80% of the parents who we see in clinic are on TennCare, which is Tennessee's essentially equivalent of Medicaid. Approximately 85% of the parents who we see are female. Approximately 50% of the parents who we see have a high school education or less. In terms of race and ethnicity, approximately 45% are black, 25% white, and 20% Hispanic. The first study that we did a number of years ago, we invited parents to view the program after clinic, and parents were asked to view at least 8 options. And after the clinic and after the parents viewed at least 8 of the different strategies, which I should mention, after a parent clicks on a strategy, they receive approximately 1 to 2 minutes of additional multimedia material and education about why that strategy that they picked was either a good option, a great option, or an undesired option in terms of responding to aggression. And interestingly, we found that after parents watched at least 8 of the different options in the program, 30% of parents verbalized that they plan to use less spanking. And so this really led us to wonder, this is really interesting to hear that 30% of parents spontaneously said that as a result of the intervention that they planned on doing less spanking. And this led to another idea of a population-based intervention, especially when you think about in pediatric primary care, where we're trying to provide care for all parents. And in this first study, approximately 50% of parents who were asked to view the program declined, and so we didn't know anything about those parents who didn't participate. And in the next study, we approached parents in the waiting room, and this is study 2, and parents were divided into 2 groups. In the first group, a research assistant approached parents and asked the parent in the waiting room if they would be willing or interested in reviewing some information about discipline. And in a second group of parents, the research assistant approached the parent and essentially instructed the parent that the next part of their clinic visit was to review some information about discipline. And we were pleasantly surprised to find that all the parents in both groups said that they felt like it was a valuable part of the clinic visit, and we were able to get 100% participation in the group who were instructed to watch the program, but we only had about 40% participation in the group in which the intervention was optional. And so we felt like that was some positive response to parents, and that perhaps we can incorporate it into the well-child visit. In Study 3, we performed a slightly different protocol, and in this study, we randomized parents of 1 to 5-year-old children to view either 4 of the interactive options in the interactive part of the program, or just to receive routine primary care. And this was done immediately before the clinic visit with the physician, and in the intervention group, parents viewed at least 4 of the different interactive options. And then after the intervention, the physician had the well-child visit, and then after the physician visit, the research assistant reapproached the parent and asked parents the following question: as a result of your clinic visit today, do you plan to change how you discipline your child or respond to your child's behavior in the future? And if the parent answered yes, parents were asked what exactly they would do differently in terms of their change. And in this figure 1 in Study 3, it illustrates the proportion of parents who plan to change how they discipline. And we found that in the intervention group, 83% of parents said that they planned on doing something different to discipline their child, as compared to 7% in the control group. We had a subset of parents whose primary language was Spanish, and for the Spanish-speaking parents, we found that 91% of Spanish-speaking parents in the intervention group said that they planned to revise how they discipline, as compared to 12% of Spanish-speaking parents in the control group. We also looked at the proportion of parents who planned to use less spanking, and we identified 12 parents, all in the intervention group, or 9% of the entire intervention group, who said that they planned on doing less spanking, as compared with 0% in the control group. Now, if a caregiver stated that he or she planned to use less physical punishment, the research assistant went on to ask an additional open-ended question, and that was, what did you see or hear during your visit today to cause you to consider using less spanking? And the following slide lists a few of the responses that parents said in response to the question in regard to what they saw or heard that caused them to change how to plan to spank less. And 7 of the 12 mentioned the video and or their physician. Moving on, Study 4 is entitled "A Brief Intervention May Affect Parents' Attitudes Toward Using Less Physical Punishment." In Study 4, we studied a scale called the Attitudes Toward Spanking Scale. And this 10-item scale was developed by Dr. George Holden, and it's 10 questions, and Dr. Holden and his research team in Texas has determined that if parents score really high on this scale, then they are more likely to use physical punishment at home. And so the key measure in this study was the Attitudes Toward Spanking scale, and if you're interested, the score is summed, and it can range anywhere from 10 to 50, and higher scores on the ATS are correlated with a greater likelihood of using physical punishment. And in this study, we were able to obtain a ATS score on parents in both the clinic and in a local preschool before they viewed the interactive options in the Play Nicely program, and 4 months after they viewed the program. And we found that in the intervention group, there was a significant decrease in the ATS score by 2.7 points, which was significant at P equals 0.01, compared with the control group, which 4 months later did not have any decrease in the ATS score. Finally, we have one more study, which is Study 5. And in Study 5, we randomized a group of clinic patients to either receive the intervention or to be in a control group in which they just received routine primary care. And the intervention group was instructed to view at least 4 of the different options in the program. And after the clinic visit, the parents were asked about their attitudes toward spanking as determined by Dr. Holden's attitudes toward spanking scale. And the results of Study 5 are listed there in Table 2, and we found that in the control group, the ATS score was 30.0 as compared to the intervention group. The ATS score was 25.9, which was statistically significant. And again, higher scores are associated with actual use of physical punishment. So in summary, we've studied a brief educational intervention which has been tested primarily with underprivileged and minority caregivers, and we've been able to find that this brief intervention can at least have a short-term effect on parents' plans to discipline and a short-term effect on parents' attitudes toward using less physical punishment. We found that a proportion of parents, somewhere between 9 and 30% who watch the program, at least in clinic, spontaneously will verbalize that they plan to use less spanking. And also we found that it is possible to use a population-based approach in which the program is essentially integrated and parents are instructed that the next part of their clinic visit is to learn some aspects about discipline. The implications of our work is that this work may be able to affect parents' attitudes toward using less physical punishment, and the implications are also that we may be able to improve primary care offerings for parents, especially related to violence prevention and early brain and child development. Certainly, these are short-term studies, and much longer-term studies are needed. I do always like to leave my contact information if there are people out in the community, such as yourselves, who are interested in studying the program or just using it or have questions. Feel free to contact me at my Vanderbilt email address. Thank you so much, and I will turn things back over to Christy and to Kathy.
Okay, Dr. Scholar, thank you very much. Some great information, some interesting studies presented today. Certainly a lot of interesting things to talk about. Kathy, do you have anything to add or comment on as far as Dr. Scholar? I know you two probably work very closely together, so this information for you is probably not anything new.
We're working on it. No, it's just, I mean, my only comment is that I think it's fantastic because I think it's so important to get pediatricians involved and in a way that's feasible for them to get involved and relatively easy. And so I think it's a great intervention. I'm excited about seeing more results from it.
Right. Encouraging that, Dr. Scholar, he is a pediatrician, it's hard to change pediatricians' views, and some of them say, spanking is okay. My pediatrician, for instance, say, hey, you got to pop them a little bit. That's okay. Obviously we don't want you beating your child, but some of them do have the view that spanking or some form of punishment like that is okay. So how do you get them to maybe shift their views, shift their norms, something
That's
like
exactly why we're doing this talk today.
Right. Right.
Because I'm hoping it will reach professionals. As well as any folks that are doing work with parents and their children, because we know that we're at a point where we're still never mind working on the general population, but trying to work with professionals around their own beliefs. We're all part of this culture, so we grew up with the norms. These, if you were spanked and that's the norm, that doesn't shift if you're a pediatrician automatically, or a social worker, or anybody else. So there's a need to do education with professional groups as well.
Hard to get believers in the just the studies. It shows, these have adverse effects when you see so many other people that say, yeah, I spanked my kid, or I was spanked as a kid and I'm fine, didn't bother me. Hard to get folks on board with believing some of the evidence, or do you find...
Absolutely. I think, again, because people come from their own experience. It's like, that's why I try to bring it back to examples where, you know, people may remember quite well that they were definitely put at risk earlier in their lives, whether it was they didn't use, you know, their parents didn't put them in car seats, or maybe their parents smoked when they were in utero,
Right.
you know, and they were exposed to risks. But on those points, we now have enough convincing evidence, and the information, not only do we have convincing evidence, but the information's gotten out there to the general public that basically the risks outweigh the benefits of not doing those things. Let's say of not using a car seat, or of smoking in front of your kids. And we're trying to get there with this issue of corporal punishment, and that's one of the reasons for doing this kind of talk.
Very good. We have a phone call that has come
Okay.
in, so why don't we go ahead and take that caller from New Orleans. Hello, caller.
Hi.
My hometown.
Yeah. How are you? Go ahead with your question, please.
Okay, my name is Betty Robinson. I am a child care health consultant connected with my resource center at Jennifer Children. My primary question is this. Since a lot of our population, African-American population, seem to intersect with pediatricians and acute care facilities through the emergency room. But they do go to church. And I do notice that in Dr. Taylor's comments that she mentioned that church leaders were involved, but I didn't see the emphasis placed upon the magnitude of involvement as opposed to pediatricians. And I was wondering, since that is a resource, and we're looking at where people go and getting the information out, what strategies are going to be used going forward to involve the different religious groups in getting a mind shift in terms of corporal punishment?
Well, I'm going to look you up when I get back to New Orleans and talk to you about that, because I have the same kind of questions. Like I said in the talk, I provided a couple of resources that have been used globally to try to engage religious leaders. I don't personally yet have a specific strategy or intervention, but it's something I really want to work on with, frankly, anyone who's interested. So anyone who's listening and who has some ideas or thoughts about this and strategies they've used, we're all ears, because we know that this is so important to work with the community and to get religious leaders involved and on board. And like you said, for some people, you know, those are the folks they're going to listen to, and that's where they're going every week. And so basically I'm agreeing with you, we need to do that. And I think for now I would point you to those two resources that I provided on that slide about engaging religious leaders for ideas about interventions.
Okay, very good. We have just a couple of minutes left. I would like to give you and Dr. Scholar, if he's still on the line, a chance to just give some final thoughts. There was a lot of information presented today. What are the main things that you would like the audience to take home today? And Dr. Scholar, are you still there?
Yes, I am, Christy.
Okay, why don't we go ahead and start with you? I know you're on the phone. That way we can kind of let you go if you need to go. What are the main points you want folks to take away from the presentation today?
Thank you, everybody, for listening in. My feeling is the main points, Christy, are that we now have a lot more data than we did a few decades ago that indicate that physical punishment, especially harsh physical punishment that goes on for month after month, year after year, can really have detrimental and long-term effects on people's both physical and mental health. And the second main message would be that there are interventions out there that with which we can use a population-based approach to start changing more people's attitudes about using physical punishment.
Okay, great. Well, Dr. Scholar, we are so grateful for you to taking the time to join us today by phone. A lot of great information. So thank you so much for taking the time to be here and present the information that you did. We really appreciate it. Well,
thank you, Christy, and thank you, Kathy.
Great, thank you. And Kathy, finally, we'll let you have the last word here.
Yeah, I'll just say that, as I've already mentioned, that I think we're doing a good job implementing some high-risk approaches like the nurse-family partnership. We can always expand that. There's always need for more. But I really hope that people will leave today with a new appreciation for how we might start to take some of these population-level approaches, really engage the larger public on this issue, And I'll second what Dr. Scholar said. You know, we know now, we have so much evidence that using corporal punishment, even though it's cultural, it's part of our history and tradition, but now we know it's not effective, it's not necessary. We have alternatives that don't lead to harm for children that we can use. I hope that we as professionals can start to promote that, thinking about what's best for our children's long-term health and well-being.
Right. Very good. Well, Kathy, thank you so much for being here and for the information
Thanks for having me.
you presented. You're welcome. Come back anytime.
Great, I will. Thanks.
And again, for those of you out there who want more information, the handouts are available online for you. Both Kathy's and Dr. Scholar's information, their contact information is available in their handouts if you want to contact them for anything. I know we had that caller, Kathy, that you said you wanted to get with, so hopefully...
Please get in touch, yes.
Yes, definitely contact them if you have any further questions. This does conclude today's presentation for today, so we do hope you learned something beneficial, and we do hope you have a great rest of the day. Thanks for tuning in. We'll see you next time.